What are the challenges in the South African healthcare system? Why is healthcare a problem in South Africa, and how can South Africa improve its healthcare system? Hello and welcome. I'm your host, Dr. Musam Tombene, and signing with us today is Trifosa Nzolengwe. On Vital Signs, we'll look at the state of healthcare in South Africa with the focus on the Northwest province. Coming up on the program, we'll hear from patients in the Northwest as well as Gauteng clinics about the experiences that they currently have with the healthcare system. We'll speak to the National Chairperson of the Treatment Action Campaign about the healthcare issues raised in the 2022 report by civil organization Richidze in the second edition of the Northwest State of Health. We'll speak to the Northwest Health MEC about the challenges that the province is currently experiencing and, of course, what affects the provisions and, of course, the efficient and adequate healthcare services that the communities need. And lastly, we'll speak to the Acting Deputy Director General of Clinical Services at the Gauteng Department of Health about how these challenges of the Northwest and other provinces affect the Gauteng healthcare system. Remember that you can be part of the show by asking the guests that we'll have on any question that you may have on your mind by simply sharing your view on what we're discussing. The number to call is 011-714-5861 or 011-714-5877. We want to hear from you. If you don't want to call us, you can, of course, get in touch with us on our social media at SABC Vital Signs on Twitter and, of course, SABC Vital Signs on Facebook. Stay with us. We'll see you after this ad break. Welcome back to Vital Signs. Now, there are people, for example, who have to travel from one province to another for emergency medical treatment or for the treatment of their chronic conditions because of insufficient and inadequate health services to the communities and in the communities that they live in. Now, we visited the Chris Hani Baragwanath Academic Hospital in Soweto to speak to some of these patients who travel from the Northwest and other provinces to receive healthcare in Gauteng. Take a listen.
We left Klerksdorp around 5:15, come here for my mother's checkup. She's here for a scan. So we arrived here around 7 o'clock, I think. Well, we didn't get the scan, but it was quite frustrating, that one. But we received the file quickly. It's just that we just didn't get what we came here for. Because my mother, she was told that the scan is not working. So we were supposed to be called and told that the machine is not working. So actually we came here for nothing. I mean, it's winter, waking up at 2 o'clock to go to another place and she had high hopes that the doctors will finally find out what's giving her the problem, because there are things that she can't do. She's had a stroke twice and it has affected her problem even more.
Mina ngibuye eHeidelberg umthetho wami. So bengizobona udoctor la. Le eHeidelberg bangithumele la eBara uthi ngizobona udoctor. Manje nangifika la eBara bangitshela ukuthi udoctor akekho namhlanje. Uzoba khona ngolosini. Ngithathilanga lemsebenzini la namhlanje. Manje kufanele ukuthi ngizele mahala la esibhedlela. At least bangangitholela udoctor oseduze. Hayi ukuthi njalo njengoba ngiqala ukuzala futhi. Ukuthi manje ngolosini ngize futhi la. At least basitholela udoctor oseduze le Heidelberg at least.
Ke tlhaga ke le go itsoseng. Ke tlisitse ngwana mo Bara. O tla check up mo Bara. So re tlhaga go itsoseng re ya bophelong re robala go bophelong. So go bophelong ha re robala go di auto like la ka re tlile le bana yana robala le bana ba rena ko ka mo reception mo ditilong. So re emela nako ya di ambulance phakela ka 2 di a re tsaya di re tlisa kwana. Rona ha nne go ka nna le di transport tse re di re tsayang go tswa go re dulang teng because ra more ga rena le ditšhelete tse nako ngwe tla be le date ya ngwana ya check up. Ha ona tšhelete ya go tswa itsoseng go a bophelong. Re heleletsa di-date yana tshwanetse re founele ka re postpone because of tšhelete.
After the break, we'll speak to Mamsbongile Chabalala from the Treatment Action Campaign about the problems that they've witnessed and, of course, people actually experience in the healthcare system. And all of that happens after this ad break. Welcome back to Vital Signs. Now, the 2022 report, which is the second edition of the Northwest State of Health by the community organization Richidze, has yet again put the spotlight on the province. The report found that while services have improved from 2021, the Northwest province continues to have shortages of medication and other issues relating to healthcare services. To talk on more of these issues, we're joined by the TAC's, that's the Treatment Action Campaign's national chairperson, Mamsbongile Shabalala. Good morning, Ma. Thank you so much for joining us. Ninja namhlanje.
Good morning, Musa. Ngiyabonga. Siyaphila kunjani?
Siyaphila nathi. So the big thing here is, siyazi ukuthi you work with a lot of community organizations to make sure that patients' lives are actually kept, that people get medication, and also have access to services. Can you give us a roundup of what the report found?
From the report, we found out, as much as you are saying that at least the healthcare system, it has improved a lot. But in a report, what comes out a lot is that the issues of stock out, especially the contraceptives in the country, which are mostly are not available. Also, it demonstrates that as much as we are improving a bit by bit, but we still have to do more in terms of medicine shortages, because we found out that about an overall 82.5% complained about not accessing their medication. And that shows that in most of the cases, even if it's not one medication, one way or another, people go to facilities and not get their medication. As we saw on the video, when patients are saying they're traveling from far to go to Gauteng to access medication, which is very depressing. But then we also know that other challenges that we are facing are caused by the shortages of human resource and also the shortages of specialists in other provinces like Northwest. But then in the issue of stockouts in Northwest, I think that is the issue that we need to continue to engage with Department of Health in Northwest, because it's a continuous issue. It's been happening for a very long time. It's just that now we have a report that we are showing. But I would like to say it here that MEC Sambata is very open, and we are engaging with him every now and again on the issues that we are getting on the ground. So we hope that in the near future we'll be able to conquer all these challenges that we are facing, especially when it comes to Northwest. And yeah, and also would like to have other MEC responding like him, because he's very responsive. It's just that the implementation sometimes on the ground, it's very different from what the principal is responding to.
Now, the big issue is this issue of on the ground, where, you know, it's nice to have words, it's nice for MECs and, you know, and figureheads and people like that to go out and say, this is what we'd like to, you know, identify as problems and these are the solutions that we'd want. But if the patient on the ground still has this continual problem of not getting their medication or being seen by the specialist, that obviously has not solved the problem. So what are some of the big issues that have been highlighted as the cause, for instance, to the medicine shortage and the shortage of specialists?
The challenge is that in most cases, the challenge will be with the facility or will be with the provincial depot. You find that the provincial depot doesn't deliver in time while the facility has ordered early the medication. But in some instances, you find that the facility placed the order late while the medication is already nearly out of stock. So by the time the provincial depot or the district depot delivers the medication, it's already not in stock in the facility. Sometimes you find that the medication, it's not that it's out of stock at all. It's just that the communication. I think what's the problem? It's communication between the two departments, with the depot and the facility. And in some instances, you find that nurses have to, or sister in charge, have to drive to another facility to borrow medication for patients to have. So there are a lot of challenges in the systems. I think what we need to look at are the systems of how medicines are delivered and how medicines are ordered. We know that we have VSS system, which the government always refers to, but it shows that that system it's not working 100% because we're still facing those challenges of ordering and patients getting medicines on the ground. And unfortunately, the person who suffers most is the patient on the ground, because when I go to the facility, I expect to get services as I'm supposed to get. But if I don't get and I have to come back on another day, then it means I'm losing 2 days at work, and it means then I'll have to spend the money that I don't have.
No, very true. Now, you've highlighted that you have spoken to the MEC of Health in the Northwest Province, and he's a very open person, and you've had these discussions. What were some of the issues that you were raising, and what are the actual outcomes that have come out of that?
We've spoken about the issues of shortages of medicines, and he acknowledged that there are problems. And what we like most about the MEC of Northwest is that he said to us, please give me the clinics that you find shortages so that I will go and do unannounced visits so that I will see what is happening on the ground. So, but the challenge is that sometimes you will go to the facility as TAC today and you don't find, or Richitza, you don't find the medicine. The medicine is delivered tomorrow. When the MEC goes on the third day, there is medication. And what we found mostly is that healthcare workers are not also honest to their principal to tell them to say, okay, yes, now we have, but in the past 2 days or in the past week, we didn't have medication. So that's the problem that we always encounter. But I want to emphasize this because I would like also other MECs to respond like what MEC Sambasa does. Most of the MECs, we have to ask them, we have to dig them, we have to postpone meetings. But with him, it's easy. We just write a WhatsApp, he responds to the WhatsApp. That's the response that we need from the principals. But what we wish is that even people who are working on the ground can be responsive as he does. So we hope that while he's still the MEC, things will go well. In the Northwest, he's coming in the right way to fix the Northwest. I'm not praising him because he's here. He knows that we are very frank with issues if we are not happy. Yeah.
Now, another big issue, and I think this is an issue that is found in many provinces that aren't very urban, for instance, right? So the Northwest, Limpopo, Mpumalanga, and places like that, would be the issue of healthcare facilities in terms of infrastructure. How are these challenges being met?
It's difficult because, you know, as much as we always say, and now we don't have to blame the apartheid era, but we are still struggling because of the damage that happened years and years ago. Services are not, like facilities in most cases, even here in Gauteng, the condition of infrastructure is very problematic. And we are seeing hospitals, big hospitals like your Bara, your Charlotte Maxeke and Rahima Musa. If you can go and visit those hospitals, you'll find that infrastructure is still problematic. Then we need to sit down, government, civil society, and everybody around the table and see how can we resolve the issues of infrastructure, because infrastructure is a key. We can't work in a facility that has a storage that is not maintained. You can't work at the facility that has toilets that are broken. Patients cannot be able to access toilets. You can't work in a facility where patients have to wait outside to be seen. Especially COVID has exposed us a lot to say we have small facilities. Our healthcare facilities are very small. They cannot cater for everyone in the country. People have to wait outside in the sun, in the rain. Yes, there are those who try to make shelters, but that is not enough. And also the issue of human resource, it's also problematic. I think while we are talking about infrastructure, we cannot leave it out. The issue of human resource shortages of specialists in the country, it affects people on the ground mostly. And it is unfortunate that most people who are suffering are people who are poor, who don't have anything on their pockets. People who can manage, I'm sorry, MEC Sambat, I'm going to make an example about you. I think you have a medical aid where you are, and you are able to go to private hospital, I mean to say, they have medical aid, they have all the specialists, but in the public sector, we don't have. So then, what does that mean? It means then we have to have a discussion, private and public, to say, how do we bring this perspectives from the private to the public? Because we know that private sector only supports 16% of our population. So what about the 84% of the population that cannot be able to access the best services that we can get in the country? And I know that for the fact that we do have specialists, but specialists are after money and at the private. But how are we paying our doctors and making sure that also we have a conversation with their unions to say, how do we meet each other halfway? Because the important thing here is it's a patient's life. It's a right to health that needs to be provided to people on the ground.
Well, thank you so much, Mamsibongile Chabalala, the national chairperson of the Treatment Action Campaign. After the break, we'll speak to Madoda Sambata, the Northwest Health MEC, about the challenges that the province is currently experiencing, which affect the provision of efficient and adequate health services to communities. Stay with us. Welcome back to Vital Signs. A recent study report, of course, about the Richidze report, which is an organization that shows that facilities within the healthcare system in the Northwest are still plagued by various challenges, including shortages of medicine and vaccines. Now, the organization uses a system of community-led monitoring that has been developed by people living with HIV and activists to hold the South African government and aid agencies accountable and together improve HIV and TB service delivery. Now, the report states that there were 398 reports of shortages of medication across 57 facilities. Now, according to the report, this is one of the major reasons that led to patients defaulting on their treatment. Our reporter Silwane Kakao and video journalist Nduduzo Ngosi visited some of these clinics in Mafikeng and Kanana in the Northwest and compiled this report.
In some villages in the Northwest, healthcare facilities are far removed from the locals. Many are from impoverished areas plagued by social ills, including unemployment and poverty. They do not always have money for public transport and are walking a couple of kilometers in adverse weather conditions to collect treatment at healthcare facilities. Arriving there, they have to queue for hours and hours, at times only to return home empty-handed because there is no medication. Residents say this is one of the major reasons that discourage them from going to clinics.
At times, we are only attended to after 6 p.m. due to long queues. When you are finally helped, you are told that there is no medication.
Sometimes we're given 5 tablets each. They would say they are sharing them amongst patients because there isn't enough of them.
They told me that they don't have the medication that I need. So they wrote a prescription for me and told me to go and buy them at the pharmacy. I'm unemployed.
According to this report by Richidze, shortage of medication is one of the major reasons leading patients to defaulting on treatment for serious illnesses such as hypertension, tuberculosis, and HIV.
The Northwest is lagging behind in extending the supply of ARVs, with just 6% of people living with HIV interviewed reporting a 3-month ART refill, compared to 25% in the same reporting period last year.
The report by Richidze states that the long and tedious waiting period that the patients often complain about at healthcare facilities has actually seen a slight improvement this year compared to the previous year.
Waiting times have improved in the province, down from 5 hours to 4 hours. However, we do have 91% of public healthcare users interviewed who think that the waiting times are still long.
The Northwest Department of Health says the past 4 years have come with great challenges that impacted negatively on ensuring that there's always medication at healthcare facilities.
Since 2018, during the strike, there was a problem of shortage of medicine because the companies couldn't deliver the medicine. And after that, also COVID also impacted negatively to us, of which some companies couldn't deliver the medicine.
The Northwest Department of Health says one of the causes of shortage of medication is budget allocation that is not enough to cover the entire financial year.
Medicine is being under budgeted, and by the time we reach November, December, before the end of financial year, the budget is depleted, and you'll find that we are unable to pay the suppliers. And when we don't pay the suppliers, they are unable to deliver the medicine. It's where we'll find that we don't have enough medication.
The Northwest Department of Health says it has since written to Treasury to increase its budget specifically for medication to ensure that public health care facilities never run out of medication. Silwane Gagau, SABC News, Mahikeng.
Long waiting hours and, of course, waiting for emergency medical services, medical shortages, high travel costs and long walking distances to these clinics. These are some of the issues that communities in the Northwest face when trying to access healthcare services, according to the second edition of the Richitse report. Now, the Northwest Department of Health has noted with concern various reports in the media regarding this alleged unavailability of medication from patients with regards to this medication being ARVs, TB medication, as well as family planning medication. We're now joined by MEC Matota Sambata from the Northwest Health Department to talk to us about what the report has said and other issues that he'd like to address. So thank you so much for joining us, MEC. I think the first question is the one that's really living in what the episode today is all about, this idea of a shortage in medicine. So do we really have a crisis with respect to access to actual medication for the patients in the Northwest?
Thank you very much. Let's start on the Bara issue you played.
Okay.
It's not true that patients interviewed in Bara, there was a patient from Heidelberg, that's Mpumalanga, there were 2 patients from Northwest. It's not true that they are in Bara because in their provinces there are no medicines. It's patients who are formally referred to Bara for any treatment or care that in their provinces, specialists are not in availability. So it's a formal referral. It's not a person who wakes up and go to a clinic in Klerksdorp or in Northwest, find no medication, then take a taxi to Bara. It's not true.
Yeah, thank you for clearing that up. I think that was an important note.
That background can create chaos because tertiary hospitals in South Africa are a national responsibility. So any referral to a tertiary hospital, even if a patient is from Free State referred to Klerksdorp, Tsepong, it's not regarded as lack of medicines in Free State. It's formal referral. Let's leave that one. The second one is the issue of availability of medicines. It's both true and it is on the grounds of many reasons. One, you have a situation where management in facilities, it's not able to keep up with responsibilities. What responsibilities? There's a national program, national system by the Department of Health, where all the clinics and health facilities in the country are in the same system, province by province. In that system, it's used to monitor availability of medicines on daily basis. Because we're a caring government. It's used to determine which clinic today has less availability of which medicine. The only problem you have when I say management, they are expected to scan each medicine that is received in a facility. They're expected to scan each medicine that is given to a patient so that the system remains true to what you have and what you don't have. In most instances, facility managers do not monitor scanning. So what happens? In Clinic A, they would have received medicines today, they are not scanned. If you go to the system, they are still recording as a shortage. Or in Clinic B, you may find that they've scanned availability. They have not scanned how many have been distributed to patients. That was meant to monitor exactly availability of medicines. Had that system been properly managed by managers in health facilities, it would help South Africa to understand on a daily basis as it was meant for. That one is an issue of management. You keep dealing with the responsibility of managers to ensure that that system is used as it was meant for. The second issue that arises out of management is that you do not understand why a facility manager, when she or he is to knock off, would not check stock availability for tomorrow. So that when that facility has a lesser number of availability, before knocking off, arrangements are made first with the nearest facilities, secondly, with the sub-district, or thirdly, with the district, and then fourthly, with the medical store provincially. Manager just simply knocks off, not knowing and recorded stock availability. That's an issue of management.
Yeah.
Thirdly, on the medicines, the real one. First, the issue of the budget. We do not have enough budget for medicine provincially.
Okay.
Secondly, the issue of owing suppliers, which is history now. We had to pay suppliers that were owed from 2012. I can tell you, in 2020, paid them off. The reason is, once owing accumulates, they then take a decision to put your account on hold. When your account is on hold, it means even if you need medicine of 2 million now, they say first pay 9 million you owe us, which therefore means it becomes too expensive for you to buy medicines because you are told, pay me what you owe before I distribute to you. You may need a medicine of 2 million today, yet you owe 9 million. Then you are expected to pay 9 million. That matter we have cleaned, thanks to the administration by the National Department of Health, thanks by the administrator, Mayor Hunter, and thanks by the department and the provincial treasury and EXCO to make availability money to clean the previous ones. So we no longer have hold. Then if you go to the medical store, there's a problem too there. This thing of scanning, you get in there, you say Clinic A is in short of medicine, so and so. They look in the system, they say we don't have it. Yet you find it packed in the shelves because it was not scanned. Scanning is critical. But a day after I delivered the budget speech, I said to myself, let me go to one facility. I went to Lihurutsi Hospital in Zerast. On my arrival, they said to me, they do not have enough medicines for the hospital. I put the medical store on call with them. That which they did not have was available in the medical store. The next question I asked them, I saw a packed boxes of medicines packed there. I asked them, where are these boxes supposed to go? For a week, those boxes should have been distributed to clinics in Zerast. And they were still in a hospital. I asked them, now the clinics do not have medicines which are packed in your store. which you should have distributed a week ago. What is the reason? They tell me is transport. That too is an element of ill discipline, irresponsibility, because had I not arrived in Zeerust, first, they were not going to know the medicines that they claim they're in short of are available in the medical store. Secondly, clinics in Zeerust, which should have had medicines, did not have them because they're claiming a problem of transport. So the issue of medicines, it's an issue that the government of the African National Congress, provincial and national, has a responsibility and agree that it cannot be. It's one of the issues that we say it's non-negotiables. We are now working with the provincial treasurer and national treasurer to improve the budget of the medicines. What I must say in public here is that my apology and sincere apology to those patients who would have gone to a clinic and they were only told after they've waited that there's no medicine. We are now working on a pilot project.
MEC, I'm going to have to interject. I have to jump in there. We'll get into that in a little bit. We have Howard on the line. And Howard, how are you? Howard? Okay, Howard seems to have disappeared. But I think, MEC, back to you. Three main points that you've highlighted here is the issue of budget, the issue of managerial issues that come with having people, and of course other issues that come with it. What are we doing with respect to addressing the issue of ill-disciplined managers and people that work within the structures that make it difficult for patients to get their medication, that make it difficult for the system that you've highlighted that tracks the medication for that to work properly, so that we're not finding patients having stockouts or feeling as if they're not getting medication because of an alleged stockouts of medication?
Remember, in the medical store, as a result of a discovery through my visit unannounced to the medical store, 3 managers, senior for that matter, are on suspension and are going through a disciplinary hearing. 3 in the medical store because of the shortage of medicine that the MEC discovered on an unannounced visit. Secondly, myself and Richidze, or myself and TAC, have an agreement that each time Richidze releases its report, I then use that report to do unannounced visit, because I can't say consequence management on the basis of a Richidze report, but I can say consequence management on the basis of what I know. There's also a gap in the Richidze report where they say, for instance, 26% of those that were asked claim to know of a person who went to a facility and did not get the medicine. They are not talking about the direct person. But the issue that I always say to people is that oversight and research by anybody helps you to strengthen weaknesses. So you don't have to argue about correctness or not. You have to go to what you are indicated are the shortfalls. If you find them improved, good, like what they are saying that there's improvement on the queues. In actual fact, the national norm, it's a maximum of 3 hours for waiting period on the queue. And each time I go to a facility, I ask the first one on the queue as to what time did he or she arrive. Once I get the time and check the waiting time, there's consequence management.
I'm going to have to interrupt you again, MEC. Howard seems to be back on the line. Howard, what's your question?
Good day. I don't have any question for the MEC, but I've been listening to the program for some while now, not from the beginning, but I heard the previous lady from the TAC say of certain shortcomings. And these shortcomings, if I compare the province I'm in to what I hear, it's not always relevant. The one was people have to use private transport, get up early in the morning. Here by us, they go to the local hospital, if they refer to the tertiary hospital. And they make arrangement with the local hospital who puts them on an ambulance taxi and transport them to, say, from Paarl to Tygerberg. They get preferential treatment there because the specialists are that side. But they also get help first because they come from a far distance so that they can come back with the same taxi.
Yes.
It is your own choice to climb onto private transport.
Yes.
It is your own choice to get up early and use your own transport. So if the people make use of the facility that the MEC puts in place in the various provinces, why aren't they using it? Now they complain there's no transport, they've got to get up early. I don't say there isn't issues. We have the same issues similar to what he has in his province in the Northwest.
Yes.
We, for instance, I know of a certain medication, they haven't had it available for the past 3 months, maybe longer. But at the end of the day, it is my responsibility to do what is necessary to be treated. I'm a high blood pressure patient, so I've got a chronic disorder. If I don't use my medication, then I'm going to have problems. And if it's not available, what did I do to get hold of it? What did I listen to when the nursing staff spoke to me?
Yeah.
There is other issues, yes. There's a shortage of personnel, also here by us. Line managers take people out of hospitals for meetings when they know there's a shortage, and then they take the manager away and they leave the clinic with, say, one specialist sister.
Howard, I'm going to have to jump in there and interrupt you. We don't have a lot of time and the MEC has to go. But I think what the caller's highlighting there, Mr. MEC, is this idea that I think you have been singing about the whole show as well. This idea that these are not isolated problems that exist in just the Northwest, that these are issues that exist in and around other provinces as well, and that it is something that has to work in a symbiotic fashion, where patients as well as the department have to come together and really work towards coming up with a solution. And of course, you as the MEC, as well as your department and other civil society organizations coming together, highlighting problems that exist, but also trying to come up with solutions, because this is not a job for just the department or just the government. It's a job for everyone, because everyone has to benefit from the system. Thank you so much for joining us, Mr. MEC, and that is Madoda Sambata, who's the MEC of Health in the Northwest, for giving us that time. It is now time for us, of course, to take another ad break. When we come back, we'll discuss more health issues in and around Gauteng, Northwest, and maybe even your province after the break. Welcome back to Vital Signs. Now, access to healthcare services is critical to good health. Yet some rural residents from the Northwest and other provinces face a variety of access barriers. This resulting in some patients seeking medical attention here in some of these Gauteng health facilities. Now, to talk to us about how these challenges of the Northwest and other provinces affect the Gauteng state of health, we're joined by Acting Deputy Director General of the Clinical Services from the Gauteng Department of Health, Dr. Stephen Mankopane. Thank you so much for joining us, Doc. I think let's jump into it. Do we, as Gauteng or other more well-equipped provinces, suffer the burden of having to take on patients from other provinces due to their failure to provide certain services?
Yeah, morning, Musa, and my colleagues and the listeners. Yeah, to get straight to the point, it is true that patients do flock to Gauteng. But Musa, I won't say entirely it's due to the shortage of services in other provinces. But you know, the movement of the immigration of people from its economic issue. People come to Joburg for opportunities, and then also goes to health. Currently, we do have patients that are coming in from other provinces. I think it's about 100,000 per annum. To seek health assistance in the Gauteng Department of Health. But then if you unpack it, there are so many reasons. And the main one being that as Gauteng, we've got higher concentration of specialist care. I mean, we've got 4 training universities, which then host a lot of super specialist professors in different disciplines. And that is the one reason why patients mostly then will be flocking to Gauteng. As the MEC from Northwest said, we have a standing formal referral route that takes patients from Northwest that are seeking specialist care. Most of them will be coming to Chris Hani Baragwanath Academic Hospital, and some goes to Charlotte. But then as we do that over the years, we have also then started building specialist capacity on their side. I mean, if you compare Klerksdorp Hospital, what it is currently in terms of specialist care, there's a lot of work done. Almost every department has got specialists, some departments more than one. We worked in collaboration. Our academic hospitals do outreach on that side, so that then we have got less movement of patients literally moving every morning to the tertiary hospitals in our province. Of course, there are patients then who are coming from other provinces, but mainly now we are having this so-called clean referral routes, so that when the patients come, they are known that they are coming to the province. They are expected by the respective clinics for the specialist care. Yes.
All right, we've got a caller, Howard, on the line. Good day, Howard. What's your question or comment?
My name is Herman Peter Cook.
Apologies,
I'm from
Herman.
Stellenbosch, South Africa. I used to do welfare work amongst the refugees in the Western Cape for approximately a decade. And while doing welfare work amongst these refugees, I noticed that the services, especially medical services, is in a very dire situation for them specifically. They don't have residence permits in South Africa. They've only got refugee papers, and then they don't get proper medical treatment. What can be done to better the plight of the refugees' situation, specifically medically in South Africa?
Thank you for that question. Sorry for getting your name incorrect. All right, you've heard the question, Doc. The issue of refugees in the country, and I think what you've highlighted in answering the question a little bit earlier on was this idea that, you know, when you've got provinces like Gauteng and the Western Cape and things such as that, when you have a big city, a lot of people move for economic reasons, and I think this would be the same thing for refugees or people that come from other countries trying to access economic riches and things such as that, or just be able to feed their families. So in terms of the Gauteng Health Department, how do we assist people that look for help in terms of the health sector without permits, or people that don't necessarily have or have legal status in the country?
Yeah. Thank you, Musa, and thank you to the listener who raised the point. It is a problem in terms of the refugee attendants when they need medical help. You know, ethically and otherwise, we have to treat them. There is a human rights matter, so that if there are emergencies, whether they are registered people in the country or not, we have to treat them. And that's one area where really it stretches our budgets, it stretches our resources, and so forth, infrastructure. And then it then results in overcrowding, because even if you are to plan around a certain community, but then you need to then accommodate patients who will be coming from the neighboring countries unregistered. In few countries, we try to to put up formal relationships, so that then the patients can be referred formally. It's going slow in terms of that process. Countries like Botswana, we get the majority of patients sent across formally, and therefore they take responsibility of the bill thereof. But other SADC countries where we know the struggles and the limitations, we get a lot of patients who are otherwise unregistered coming in to access the health of mainly Gauteng and other provinces for that matter. It's a matter that we know that even the Department of Home Affairs is dealing with, and it's a problem, because then it affects your budgetary plan and your spread of resources to offer health care in the province.
Well, I think it's important that, that's highlighted, because I think you've highlighted this a little bit earlier on, is this issue of budgets, that, when planning goes into things, you look at a population and the numbers of people that are in a certain area, so that budgets are allocated properly. In Gauteng, do we find ourselves in a position where the budget matches the needs of what we need to do for the people that we do serve?
Yeah, Musa, no, it's not at all. Not at all. The spread of settlements. You realize that the hospitals that were meant to serve certain sizes of population, in most of the situations, that size has doubled up. In areas where you have towns separated, now it's just one continuous thing. If I give you an example of the south of Gauteng, if you are going on the N1, it's almost getting the Joburg joined to Vereeniging with all the settlements that are there, and the hospitals that are supposed to serve that are mostly still the same. Of course, we try to respond to that, increase the number of clinics and capacitate the existing hospitals. But the population, it's ballooning, and we then always find ourselves lagging behind in terms of resource allocation to measure the influx of people. In migration, it's a main problem. It's main problems in many other things, but mainly so in health field where you have to respond there and offer service, and then you start getting your waiting time increased. You start getting your own situation of bed capacity affected. In Gauteng, we have made a revision in the past few months to even put critical issues on the short-term plan so that we revamp the system. We have an 8-chapter document that we want to achieve in 6 months. That is looking as to how we can, reassess our finances so that it covers the overcrowding in the hospitals. It goes with security services. You have to then change things in terms of security, the documents. Another chapter talks to infrastructure, as it was stated earlier on, because infrastructure gets overstretched. The human resource issues needs to be rearranged in such a way that we accommodate the situation. Colleagues have spoken about pharmaceutical needs, because as well you work on budget for a certain number of population. But remember now, even if we had our own assessing of the population recently, in Gauteng we'll be talking about 15 million on paper, but the service is actually way beyond that number of people because of the
Doc,
issues.
I'm going to have to jump in there and interrupt you. We've run out of time, but I think we've really highlighted the big issues that you would like to address. The healthcare system and what it currently looks like in Gauteng, the Northwest, the Western Cape, and all the other provinces, and what we could find ourselves in the near future. Most importantly is what is on the ground, what the patients actually experience, so that we limit the shortages, we limit the difference, and of course the time it takes that you wait in a hospital, but most importantly, get you healthier as soon as we possibly can. There are solutions to this. We just need to go out there and put them out and make sure we work towards getting you all right. From us here at the Vital Signs team, thank you to all the guests that joined us today, and thank you to you for watching. We'll see you again soon.